It's nice to see everyone here. Welcome to the session. My name is David Marcus. I'm a pediatric neuropsychologist right here in Atlanta at Children's Healthcare of Atlanta. And today the topic of this session is the neuropsychological evaluation and what it can tell parents. And I'll go through slides. We can also keep it casual, so if people have questions as they go along, I'll try to answer them. I'll also save some time at the end for more formal questions. Okay. Just to give you an introduction, I'll talk a little bit about my position here in Atlanta. Also talk about what neuropsychology is, what a neuropsychological evaluation comprises, what the neuropsychological evaluation can tell parents, how it can be informative, and then talk towards the end more about the specific implications of a neuropsychological evaluation for individuals with X and Y chromosome variations. Because I am a pediatric neuropsychologist, a lot of the topic and a lot of the content will be related more to kids and children. If there are specific questions related to adults, I'm happy to answer those at the end as well. So first, I'm employed here in Atlanta by Children's Healthcare of Atlanta, and for those of you who are not from our area, we're the largest pediatric healthcare system in the state of Georgia. We draw from a lot of the surrounding states and areas as well. These are pictures of 3 of our hospitals. One of them is located right down the road here at the Emory University, and then we have a couple hospitals as well. Our system is also spread out through the region, so in addition to the 3 hospitals, we have a specialized autism center, 20 different neighborhood locations, and telemedicine locations throughout Georgia. So we're really a pretty distributed system. If those of you who are new to Atlanta have been driving around, you may see our billboards and advertising. Our logo here has the Will and Hope are the names of our mascots, and they're located throughout the city on a lot of billboards. I'm part of a department of neuropsychology within the hospital. I have a number of colleagues that work with me. This picture's from a few years ago. We have a fairly large department. Right now we have 12 pediatric neuropsychologists, and the neuropsychologists that I work with collaborate with a lot of different departments in the hospital, so in genetics as well as things like neurology, neurosurgery, rehabilitation groups, as well as many of the other medical specialties. We work with children from birth to 21 years, and we work with children with a wide variety of neurological and medical conditions. So a lot of the children that we work with have developmental conditions that can include genetic conditions, as well as things like prematurity or prenatal exposure to substances, which can affect development. We also work with children who have acquired neurological conditions, such as a brain injury or stroke, or things like that, where a child's development may have been proceeding typically, but then something happens to impair them, like a brain injury. Our department's involved in clinical care, research, and training. As part of my position, I collaborate with the extraordinary clinic here at Emory, and we're modeled on some of the other clinics as part of the consortium throughout the country, especially the Denver model, which a lot of you are now familiar with. The clinic has a multidisciplinary focus that includes genetics, nursing, urology, endocrinology, as well as neuropsychology. And we really try to serve families who are both local, regional, and also national. So families do travel to come to work with our different providers. Some of the team members are listed here, Dr. Talboy and Dr. Close, and the other members are presenting as part of the conference. We also have genetic counselors and nurses and staff who are a big part of the clinic as well. So the first topic that I want to address, because I've already used this term and people may not be familiar with it, is what is neuropsychology? So neuropsychology is a specialty area within psychology that really attempts to try to understand how the brain and behavior are connected. So understand for a child's cognitive development or behavioral development, how that relates to their brain's functioning. Another way of saying that is we try to study what the psychological implications are of different neurological conditions. So if there's a condition such as a genetic condition like XXYY or Trisomy X, what are the effects of that condition on the child's thinking, learning, behavior, and emotional functioning? And within a clinical field, like I am within the hospital, what we're primarily doing is using different psychological tests to assess cognitive functioning in different areas and then make connections with those underlying brain structure and functioning. So in addition, what is a clinical neuropsychologist? What kind of training would a neuropsychologist have? Neuropsychologists would have doctoral training in clinical psychology, so it would tend to be a PhD rather than an MD, and that comes into play a lot in that the neuropsychologist is not going to be the one who's going to be involved in directly prescribing medications. That would really be the physician that they'd be working with or that you would be working with in your family. The training in neuropsychology involves specialized coursework, such as neuroanatomy. So compared to other psychologists, the neuropsychologist probably has more background in understanding the brain's development and the brain's functioning. A lot of times we'd also be trained in working in clinical settings, such as working in medical settings and hospitals, and also experience in collaborating with MDs, nurses, therapists, different people working in that medical setting. Neuropsychologists can be trained to work with patients throughout the lifespan, adult patients, geriatric patients, and obviously pediatric patients, and that'll be more of the focus of my talk on the pediatrics. In pediatric neuropsychology, we'd be working with infants, children, and adolescents, and a pediatric psychologist would be expected to have knowledge of development, such as how the brain and nervous system develop, how children's cognitive and emotional functioning develops, and also really to recognize what are typical or atypical patterns of development. Some additional considerations that someone trained more in the pediatric side would be focusing on compared to an adult neuropsychologist would be things like the role of the family and the environment, the child's development up into the point of working with the child and family, and also what are the educational implications. So because children are spending the majority of their time throughout the school year in school, what are the implications of the neurological conditions for their learning, and what kind of academic setting are they in at that point? So this slide sort of presents just a real basic schematic, but how I sort of like to think about or conceptualize the neuropsychologist's role. We sort of serve as a go-between between different systems that we're involved with. So we obviously have direct interactions with the family in terms of talking with parents and understanding the family's situation and expectations and concerns. Neuropsychologists also may have direct interaction with the school in terms of reading individual education plans or IEP plans, in terms of recognizing that if there's different, trying to understand what types of educational setting the school has, what types of instructional style, what types of resources they may be using to try to help that child. And also, especially within the hospital setting, the neuropsychologists will have direct interactions with the medical providers. So it can be collaborations like I have with our extraordinary clinic and the providers there, or with different departments as well. So one of the ways that I like to think about this is that neuropsychologists are probably trained in a lot of different languages or learning to understand different languages of the different systems that they work with, and to try to serve the families because of that. So we know that a lot of times families may be talking with a medical provider and may not understand exactly all the details, but if they need to share certain information with the school or to explain things to the school, a lot of times the neuropsychologist can be helpful with doing that. And similarly, a lot of times there might be a medical provider who recognizes by working with the family that this child is having school problems or learning difficulties, but they're not exactly sure to what degree it is or what the family really needs to do with the school. They'll be able to utilize our services to really provide a more detailed assessment and recommendations of what the child needs in the school setting. So for the next part would be addressing what is a neuropsychological evaluation, because that's primarily when I'm working with families in a clinical setting. We're performing neuropsychological evaluations. And what these evaluations consist of is using psychological tests to assess cognitive function. So the types of goals we might have, and it may be different across families. A lot of times the goals are to identify a child's particular strengths and weaknesses in terms of cognitive areas. So they may be stronger on visual processing and visual learning skills. They may have more difficulty with verbal or language skills. They may show particular difficulties with attention or memory. Those types of things might be some of the areas that we look at. We also attempt to establish a baseline level of functioning. So sometimes it can be really helpful, and I know it's been addressed in other sessions here, that when there is early identification of a particular X and Y chromosome variation, to establish what is that child's level of functioning and to try to get a sense, even before they might be having problems, of where some of the risks are. Another thing the neuropsychological evaluation can help to address is what changes occur over time. So a lot of the patients that we see back periodically. It may not be every 6 months, but a lot of times it might be over a 2 to 3 year span where we're able to try to address what progress a child has made, what types of interventions have been helpful, what haven't been helpful, and make sure that the needs that that child has within their systems, within their school setting, are really matching up with what their skills are at that time. A lot of times when we do repeat evaluations, we may be trying to tag those to a time when a child is transitioning in school, such as moving from elementary to middle school, or middle school to high school, those types of things. As I mentioned, that the evaluation tries to interpret the data that we gather in relation to the medical condition. A lot of times one of the goals of the evaluation will be to make specific diagnoses related to the psychological and medical condition. So for example, does a child have a learning disability? Do they qualify as having an attention disorder? Those types of things, which can often help them access services through the school. As has been discussed in some of the other sessions here, sometimes the children with X and Y chromosome variations can be very challenging in terms of the diagnoses that psychologists or other doctors use. A lot of times they don't necessarily fit cleanly into this box or that box and may be showing some symptoms of a particular condition, even though they don't fully meet criteria or diagnostically have that condition. The real goal, the ultimate goal, is to make recommendations to help the family and the child, and I'll be talking a little more about some of the specific types of recommendations that we can help make. At the bottom of this slide, some specialty areas that neuropsychologists may be asked to address are whether a child meets disability criterion, such as for Social Security income, whether there may be some specific issues related to their transition to adulthood, what they need to know as they approach the end of high school or thinking about vocational or post-secondary educational opportunities, and also kind of on a related topic, around the time when children turn 18, there may be questions around guardianship and what type of decision-making capacity they have to make decisions about their own care or manage their own finances. So those are some specialized goals which can come up in the evaluation as well. One of the topics that comes up a lot in working with families is the question of, well, how does a neuropsychological evaluation or how does a neuropsychologist, what we do, differ from some of the other similar terms or related terms? So as parents and families, sometimes you'll hear about psychological evaluations or psychoeducational evaluations, and it may not be clear how those might relate to a neuropsychological evaluation. Some of these terms, psychological evaluation, also can be done by psychologists, and a lot of times we'll be addressing the same types of things, so cognitive functioning, educational skills, a lot of the same types of things that the neuropsychologists may be addressing. Psychoeducational evaluation, very similar as well, would likely be done by a psychologist, and as you can tell from that term, maybe really focus more on a specific educational question. So does the child have a learning disability? Does the child have ADHD? Those types of things. And, in our community, in a lot of places, there are excellent clinical psychologists that can perform, excellent assessments. They're maybe more likely to have general clinical psychologists in a community than a specialized neuropsychologist. So they can really do a lot of the same types of things. The biggest difference probably comes within the training of the psychologist. So as I mentioned, the neuropsychologist is more likely to have the specific medical background, to have had more training in brain development. And also, depending on the situation that you're working in, the neuropsychologist may have more of the direct connections with the medical team. So if you are working with a neurologist or behavior specialist within a medical system, that neuropsychologist may have the advantage of already being part of that system and working together with a team. School psychology evaluations, as the name implies, typically would be within the school system or someone employed by the school system. A lot of the types of tests that a school psychologist would do would also overlap with some of the tests that the neuropsychologist or general psychologist would do in terms of looking at intellectual functioning or academic skills. I think the biggest difference that we tend to see is that the school psychology evaluation has a more limited purpose. Typically, it's being used to determine, does this child qualify as meeting services within the school system? So do they qualify as having a learning condition that needs additional services, or that would qualify them for receiving an individual education plan in the school setting? Educational assessments is a more general term, but also may address just a child with different learning difficulties. Developmental evaluation typically is focused more on younger children, so usually, birth through 4 years old, birth to 5-year-old, where they may use some different tools than the psychology evaluation or the neuropsychology evaluation, and much more would be geared towards understanding how that child's early development is going in relation to milestones of learning to talk, learning to walk, what are their early cognitive skills. A question had come up in another session that I was in where the person asked whether neuropsychologists typically see children under 4 years of age, or they were having a hard time finding a neuropsychologist to work with a young child. And that certainly can be true. I think a lot of neuropsychologists probably focus more on school age and adolescence, and they may have specialists that do more of the developmental assessment when children are young. So some of the comparisons I've already mentioned is that in providers who are conducting any of these evaluations, they may utilize some of the same tests, may make some of the same diagnoses, but they may vary in how comprehensive, how many different areas they look at, and also they may have different types of training, and the goals really may be different. So again, to reiterate, the neuropsychological evaluation really is trying to connect some of the findings that we see from the tests in relation to brain functioning or brain development. I know this is a question that comes up a lot for parents in terms of understanding these different terms. Are there any specific questions related to this that anyone has in the audience?
Wondering about, as we get into the 20s, though, a lot of what you're talking about is directed to the school age children.
Yes.
Running the situation now, post-secondary education, dealing with some of that, and want to get you off track to the extent that you do.
Sure. So the question was, the gentleman asked for a patient who's in their 20s, who's no longer in the public school system. I guess the question is what type of assessment or how to access those types of assessments?
Correct.
Okay. So I think it can be challenging as well. Like a lot of medical providers who work with adults, sometimes they're not as familiar with some of the genetic conditions or conditions that may be associated with childhood. There are adult neuropsychologists, though, that would be able to perform similar types of things, similar types of assessments. But again, it may be a little bit harder to find ones that are integrated with other care providers, because that tends to be more of a model in the pediatric hospital systems versus adult hospital systems. But there are certainly adult neuropsychologists in different communities that could probably address that. And for, I don't know, for the particular question, but many of the colleges also, many of the states through their public college systems have mechanisms to provide evaluations and assessments for individuals who are enrolled within a college level or in a public system. Like I know here in Georgia, we have a system called the Region Center, which can evaluate any child who's been accepted and enrolled within any of the public universities or technical colleges within our state. So I know other states have some similar mechanisms as well.
And they're prepared to accommodate or tailor some of their programs to such adults that need that assistance.
Right. So the question is, are the schools prepared and have the ability to do that? Again, it's not my area of specialty. They're definitely, it's a hugely growing field compared to probably where colleges were, say, 10, 15, 20 years ago. There are a lot more colleges and a lot more programs that are beginning to figure out how do we provide either adaptations to educational systems or in a lot of cases even specialized programs for individuals at the college level or in adulthood who may need some of those accommodations. So it definitely is a growing area that I know a lot of colleges and vocational schools are really kind of grappling with. How do we support learning in individuals beyond high school? Okay. Yes.
School evaluations, our experience has been specific is they do an evaluation which seems kind of like we're explaining to them what KF is and what's going on there. And then the remediation is 1 hour a week or 1 hour every 3 weeks. And we don't have like maybe it's you or a few specific resources like the defense that we are like back now. My wife and I write letters back to them, explain things, but sometimes it doesn't really get through that. So what resources do you have?
So to paraphrase the question, so if a school has done an evaluation and they've assessed the child and are making a recommendation, such as 1 hour of a speech therapy a week or 1 hour of this, and it may seem underserving the child, or the child really may require more than that, how to assess that or how to address that with the school. So in terms of resources, I know it's not clear cut. Part of the AXYS consortium is working to develop some consensus statements and publicize those and place those on websites so that there may be more information to refer to be able to say, well, for children with XXY condition, the general expectation is 2 hours a week or something like that. So we're trying to develop a little bit more of those levels. I think having an outside psychologist who's not within the school system can give you a little bit more of a broader recommendation there. From the school's perspective or the school psychologist's perspective, obviously, as you know, it becomes a question of resources and individuals spreading around resources, and that does become an issue with the school. The other issue that a lot of times relates to individualized therapy services within the school, such as speech therapy or occupational therapy, is those therapists within the school system are really mandated to provide services that help that child in their educational goals. So if an occupational therapist in a school setting is really trying to help that child with they may be really addressing handwriting because that has a direct implication for their educational setting. If that same child has, broader fine motor difficulties and they're having trouble buttoning their clothes or carrying out other day-to-day activities that become more of an issue at home and in their daily life, the school occupational therapist doesn't necessarily have the mandate to do that, or they're not being supported to do that.
So okay. To your first point, we've come up short. We could hire an attorney to fight these things. And the downside is there's a repercussion on my son, right? And the cost associated with that. And in the end, we really get it, right? I guess a state-by-state guideline or what you see for public disability, would that be like, specifically for him, writing is a problem.
Right.
So taking notes is a problem. So remembering and then going for a test is a problem. You explain this to somebody, well, you get an hour every 3 weeks, that's just not enough.
Mm-hmm.
Taking someone's learned to listen to notes. So it's been frustrating for us. If we had a guideline like, hey, kids who have dyspraxia or whatever kind of disability, on average get 2 hours a week. This is what the standard is across all states. This is what we want. It's more for us to
Right. So again, to paraphrase, the issue being that parents that may have limited options in terms of working with the school, hiring an attorney, or moving to the next step in terms of working with the school on that, or having it become a more confrontational issue. But also, are there guidelines in terms of X number of hours for a particular condition? And I don't think that I don't know that we have any specific guidelines where we can say all children with Klinefelter syndrome must have 2 hours of 2 hours of occupational therapy. And again, in terms of different systems, as a neuropsychologist or as a community-based clinical psychologist, we can make recommendations or make suggestions, but the school isn't necessarily obligated to follow everything that might be recommended. They have obviously their own decision process and their resources. We do have a lot of families, obviously, that I work with or that we see where they're receiving both school-based therapy service and therapy services outside to address more of the general needs that may be affecting the child in their daily life. Thanks. So let me proceed on to the next part. So I think I've alluded to a number of these things already, but to give you just a little more details for those of you who have not had either neuropsychology assessments or psychology assessments within the family, usually the neuropsychologist or psychologist will be trying to gather multiple sources of data, so interviewing the patient and the family, gathering information from the school like teacher reports, taking into account things like the patient's history, birth and developmental history, medical background, educational situation, social and emotional development, gathering behavior observations from working with the child, using things like standardized rating scales that might give us more of a perspective on social functioning or emotional functioning, things we may not see in a clinic setting. And then also gathering objective test data, so information that's gathered in a structured way and that helps us compare a performance for a particular individual with might be typical expectations for that age. And that's where the standardized or structured tests come into play. And for many of you, just real briefly, you may be familiar with something called the normal curve, and most of the tests within psychology, such as IQ tests, are designed to provide a piece of quantitative information, like a particular score that allows comparison to other children at that particular age, or allows us to compare how a child might perform on one test, such as an intelligence test, with how they might do on other tasks, such as language tasks or memory tasks. So the areas often assessed within the structured setting are things like intellectual functioning, or what would be referred to as IQ tests, different visual skills, language skills, sensory and motor skills, memory and attention, a term that we call executive functioning skills, which has to do with more complex problem solving like planning or multitasking, and also encompasses things like behavior regulation, emotion regulation. We know that children with a lot of different types of neurological conditions, but a lot of kids with X and Y chromosome variations may have some specific difficulties with these types of skills. And also we know that as children get older, the difficulties in these areas may become more apparent or may emerge more over time. Psychology and neuropsychology evaluations are also going to assess things like academic achievement, adaptive functioning, which is really how that child is doing day to day and what's expected of them. So self-care, hygiene, dressing themselves, clothing themselves, those types of things. And also behavioral, social, and emotional functioning, which, as I said before, oftentimes comes, understanding of that oftentimes comes from interviewing with families and also having families complete standardized question scales. What specific tests are done or utilized for a particular child may really depend on the individual concerns of the patient and the family. It will depend on the age of the child, because different tests are developed with different age ranges in mind. A lot of times the language comprehension or the child's language communication abilities can affect what particular tests would be given. So there are a lot of tests that involve more passive or pointing to things rather than having to have a child explain strain themselves as much if that's a particular area of difficulty for them. Similarly, test that if a child or patient has motor skill limitations, different tests might be used, and also sensory deficits. So a child with vision or hearing impairment, the assessment would really have to be tailored towards measures that can help assess their cognitive abilities taking into account those deficits. So then the interpretation of the results, a lot of data is collected as part of that assessment. The goal really of collecting all that data is to try to identify the patterns of strengths and weaknesses the child may be showing, then to integrate the information we gather from the test with the background information, with the observations that we have of the child, with previous testing if there's been any that's been conducted, and then the goal to provide interpretation and diagnoses to identify risks for that particular patient, be able to try to predict likely outcomes. I know there's a lot of research that's starting to be done, such as at Denver, around looking at young children, very young children who are diagnosed with certain X and Y chromosome variations, and start to make some of those predictions. And really the hope too would be to guide a family's expectations over time as to where, what trajectory maybe that child is on, what to expect over time with them, and then to make recommendations based on the risks that we might identify. So how can the results from the neuropsychological evaluation inform parents? A lot of times in our reports, we'll really try to separate out recommendations that may be geared mostly for the medical team, for a school team, for the family, for therapists and other professionals working with the child, and also to identify different resources that can be helpful. So some of the examples of recommendations that might be directed toward a medical team or specifically helpful for the medical team may be providing information about the child's level of cognitive functioning, the child's ability to understand information about their particular condition. So obviously a lot of the information regarding, for a child regarding their chromosomal condition is going to be dependent on what age they're at, what's appropriate at that time, what they can understand at that time. Providing recommendations about adaptive functioning, such as what their independence is for different daily living skills, how their adaptive skill development may be important to assist their transition to adulthood, how to address behavioral challenges. For the medical team, for physicians, understanding more about the child's emotional functioning, such as their level of depression or anxiety, may be important. And also all these can help guide additional interventions or therapies. So for the physician, is it important to consider pharmacological intervention, such as for attention or mood, and or something like a psychological therapy important as well. A lot of the recommendations in the pediatric field for what we do tend to revolve around school. As I said before, we understand that children spend the majority of their time throughout the school year in a school setting, and the school is really, for better or for worse, going to be the place where a lot of interventions and educational approaches are put into place. Many times we will make recommendations based on our data that the family should request meetings with the school to establish an individual education plan, and a lot of times we'll describe what type of designation we feel that child would be eligible for. So if you're familiar with the special education system in the public schools, in order to qualify for an individual education plan or receive special education services, a child does have to be considered to qualify under a number of different 12 or 13 different exceptionalities to qualify to receive those services. Most of the children that we see with X and Y chromosome variations, we would recommend either be considered under other health impairment, meaning it's a medical condition contributing to their performance, or through a learning disability designation. Sometimes students will need a behavior intervention plan, so we can make recommendations to the family to request that from the school. For children that don't necessarily need an individual education plan, if their academic functioning is appropriate enough, or if they're capable of handling a typical curriculum but may need some additional supports or accommodations, a lot of times we'll recommend what's called a Section 504 plan, which doesn't necessarily entail as many services as an individual individual education plan would, but still provides the child with some supports that are necessary based on their disability. Some of the specific types of recommendations we'd make for children in school are we may discuss with the families modified instructional settings, such as, is this the most appropriate school? Is a family considering other school options? And then within the classroom, within the school, different options such as a self-contained classroom, co-taught or inclusive classroom, or more of a typical classroom, but with pull-out or resource supports. And I think this is, also where it's important to have the individual evaluation of that child, because just because we know a child has a particular medical condition or genetic condition really doesn't tell us enough specifically to say this is the kind of educational intervention that we'd recommend. We really need to take that individualized approach for that child. Some of the accommodations that I was alluding to in terms of things like testing, do we recommend extra time or testing in a small setting, tests that may have less handwriting or motor output demand, tests if a child is expected to fill in the little bubbles on a standardized test, but yet they have significant motor skill difficulty. There are accommodations that can be made for that. Also, a lot of children with X and Y chromosome variations may experience fatigue or muscular fatigue, and we make sure that we'd recommend things like strategies such as breaks or other ways to assist that. Oftentimes providing things like a keyboard or computer use instead of writing, use of a calculator, and sometimes even just recommending things like a regular meeting with the school counselor that can help them in that school setting in terms of adjustment there. Some of the more specific academic recommendations, as we know, learning disabilities are very common across the X and Y variations. So sometimes children will qualify as having a reading disability, writing disability like dysgraphia, or even math disabilities, and we'll need some specific remediation strategies or identifying resources that can help them. So some of the recommendations from a report should address those. Also, ADHD can be very common, so making sure that there are supports within the classroom that help with that, and that can be things such as the location of the child's seat in relation to where the instruction is, making sure they're avoiding distractions, needing for breaks, different things like that. Executive functioning skills, which I alluded to before. We can make recommendations around ways of presenting information that might help assist the child with their planning and organization, general study skills that can make them more efficient in terms of the amount of energy it's taking them to do the work that they're being asked to do. Modifications to instruction related to language development. So if we know children have difficulties with their verbal skills or language skills, making sure that a teacher is aware of that and can attempt to modify the amount of information presented at one time. Speech therapy is also an important recommendation for a lot of the children we see. Additionally, motor skills, such as that impacts handwriting, note-taking as kids get higher up in school, may be directly impacted, or longer written assignments. A lot of times we'll have discussions with the family or the school around should the child really be only doing work keyboarding or on the computer versus even doing handwriting anymore. I know it's more and more of us obviously are doing less handwriting and relying more on typing or even dictation to produce written output, and that can be an important strategy for a lot of children with X and Y chromosome variations. And then finally, certainly behavior management can be an issue within the school setting for a lot of children. So different classroom strategies, positive reward strategies or systems can be put into place. And for situations where the behavior or aggression is more significant, requesting from the school a functional behavior assessment, which is more of a structured way of looking at the child's behavior. So in general, I mean, what we're really trying to do from the outcome of our evaluation is to provide strategies that the family can use at home. This may be things also like positive rewards and reinforcement, providing emotional support. That may be recommending that family works with a psychiatrist or therapist for themselves and to help the child, helping with organization at home, such as study skills, engaging in tutoring outside of the school setting, ways of promoting adaptive skills at home, such as the daily living skills. It can even be things around, around health and things like sleep hygiene or nutrition concerns that may be helpful for the child as well. So overall, one of the main goals of the outcome, or what the neuropsychological evaluation can provide to families, hopefully, is education about the child's skills, more information directly about how their medical condition, genetic condition is affecting their growth, their development, their cognitive development and learning, to provide an explanation of the findings, and really, hopefully, to give the family information and resources that they can use to work with their school, to work with the medical team, and to provide things for the child. Some examples of resources we may recommend to families. Here in Georgia, we have an extensive organization called the Parent-to-Parent Program. They have a lot of different resources that we often recommend for families that are having difficulties with the school setting or interactions with the school system where maybe they need legal advice or legal assistance. Rights Law is a national website that provides resources for special education law and special education advocacy. The website LD Online, or Learning Disability Online, also has a lot of resources regarding learning disabilities, a lot of articles and connections as well. For those of you who are local or who are in Georgia, this part of the website for Parent-to-Parent of Georgia is what they call their roadmap, and has a lot of links to different resources that can be accessed there. So if you, maybe a little small, but seeing things like programs for education, early childhood transitions, different things like that. So I think we're pretty much out of time, but if we have a couple minutes left, I can try to answer some questions there. In the middle. So the question was for a child who's had a neuropsych exam, but the handwriting was never assessed. Typically in what we do, I mean, we are asking children to do like spelling tests or writing samples where we can get a sense of that. And if there are things that seem, either atypical in terms of just neatness, how letter formation, things like that, we would use it to make recommendations. Also, a lot of times we can tell from just observing the quality of handwriting, such as the pressure that the child is using to form letters or form shapes, whether they seem to have motor skill difficulties as well. So I wouldn't say it's a large portion of what we might do in evaluation, but we would certainly utilize information from things like spelling tests to try to make recommendations for handwriting. Any other questions in the front?
How do you go about doing
Okay. So the question is, how do you go about getting a neuropsychological exam for your child? So there's different avenues. A lot of times the pediatrician, or if you're working with other doctors, may know of neuropsychologists in the area. There are different websites that have collections of resources on a national level. So one of the main organizations is called the American Academy of Clinical Neuropsychology. And on their website, they have links to different states, and you can put in a zip code, and it will identify neuropsychologists based on that zip code. There also are general lists of websites that might have links to psychologists. Like I know in Georgia, the Georgia Psychological Association has listings of different specialties of psychology in addition to neuropsychology, but you, depending on what state you are, you might have a statewide resource that can provide something like that. Any other questions? Okay. Sorry, are we out of time at the end, or 5 minutes? Okay. Well, I do have some additional slides that can address some of the specific implications for the X and Y chromosome variations. I know I've tried to address some of these already throughout the other slides, but I do have some that can provide a little more detail here. So. This is all information, obviously. A lot of you know just the details around X and Y chromosome variations, some of the characteristic medical findings, some of the prevalence of the different chromosome variations, which obviously a lot of you are familiar with. Just to talk specifically about some of the variations, so in XXY or Klinefelter syndrome, some of the physical features that would have direct connections to the cognitive development include language or motor delays, muscular weakness such as hypotonia, tall stature, things that might affect a child's physical comfort in the classroom, some different medical conditions that are co-occurring in a lot of the children. And then I think that these connect directly to some of the cognitive findings. So for many individuals with XXY, the IQ can be in the average range, although there's often variability there. Nonverbal and visual skills are often a relative strength for them. Often we do see specific language and verbal deficits, such as delays in speech development, problems specific to abstract verbal reasoning. And as we're familiar, language-based learning disabilities can occur in a large proportion of children with XXY, as well as the attention and executive difficulties, oftentimes seen as attention problems or low frustration tolerance, things that affect their motor skills within school. And also higher incidence of behavior and emotional features such as elevated anxiety or depressive symptoms. These also may increase during adolescence, so they may vary at different times. Other things related to some of the language difficulties may include things like poor self-expression, shyness, frustration. If a child is not, comfortable expressing themselves verbally, they may have more difficulties in some of those areas. And also, as we know from social development, some increased rates of autism or psychoses, especially when patients are drawn from clinical referred samples. Some of the specific types of recommendations. Many of the children with XXY that I work with are often in mainstream school settings, but may need some additional supports or help, such as remediations for the learning disability, supports for their language difficulties, supports for attention and executive functioning, motor skills, which we've talked about a bit here, other emotional support, such as working with psychologists or therapists, especially around different times like the emergence of into adolescence. A lot of times we'll recommend social skills training or consider recommendations for psychopharmacology for ADHD, anxiety, or mood. A couple of the other conditions, XYY, one of the issues there is that since not as many of the individuals with XYY are diagnosed, some of the specific issues related to their learning may be less studied. We know they do tend to have taller stature, developmental delays, some other neurological conditions. And often have generally average IQ scores, although again, speech delays may be common. Some of the same patterns as we see with XXY may be occurring in XYY, including attention problems and learning disabilities, social challenges as well. And many of the recommendations for individuals with XYY may overlap with the XXY For some of the rare conditions that we see, a lot of times we will see more severe medical problems. A lot of times we'll see more severe cognitive or intellectual functioning difficulties as well. Oftentimes that really is affecting their verbal skills and language skills. Emotional, adaptive, and behavior problems can be common. A lot of times the individuals with these conditions will tend to be more in a self-contained classroom setting or specialized education setting, but that can vary as well. And then finally, some of the conditions related to the X syndromes, 47 XXX or Trisomy X. Those can be fairly variable. Just skipping ahead, the neuropsychological findings in Trisomy X, we do see overall IQ scores somewhat lower than for controls, the stronger nonverbal than verbal skills, again, expressive language delays and language-based learning disabilities, although math learning disabilities can occur as well in the girls with Trisomy X. And some of the recommendations we make there are for different accommodations, and again also overlap with some of the other conditions, so language interventions, learning disability remediations, ways of promoting adaptive skills and emotional functioning. And I think last slide, because I know we're out of time, but the tetrasomy or pentasomy X, again, are less common and again may need recommendations for more significant special education services. So thank you all for your participation. I will be available for a few minutes to answer questions if you have them specifically. So thank you.